Welcome everyone to feedback from the PURA Syndrome Global Patient Registry. Many of us are familiar with the registry, and we look forward to hearing more about what has happened over the last year. During the session, if you would like to ask a question, please use the question and answer box located at the bottom of your screen. Following the presentation, we will have time for questions and look forward to a wonderful discussion. At this time, I would like to introduce Dr. Diana Borelli and Dr. David Hunt. Dr. Diana Borelli holds a prestigious NIHR research professorship in genomic medicine, a personal chair at the University of Southampton, and is a consultant in clinical genetics working at the interface of research and clinical service. During her undergraduate training in medicine at University College London, she completed an intercalated degree in human genetics and subsequently trained first in pediatrics and then clinical genetics. She completed her doctorate in Action Medical Research Training Fellowship in the Department of Pathology, Cambridge University, where she held an academic position before her current appointment in Southampton. She continues to see patients in clinic and runs a translational research group that drives forward functional genomics to improve diagnosis. She investigates novel causes for rare disorders, and in particular, the role of RNA and splicing in genetic disease. She was a senior investigator on one of the two first papers in 2014 describing PURA syndrome in the Journal of Medical Genetics, and has worked on PURA research since. Dr. David Hunt is a consultant clinical geneticist based in Southampton, UK. He has been a member of the Wessex Clinical Genetics Service since 2012 and has been working as a consultant since 2016. He has an appointment as an honorary research fellow at the University of Southampton. As an undergraduate in medicine at St. Bartholomew's and the Royal London School of Medicine and Dentistry, he completed an intercalated bachelor's degree in biochemistry at University College London. He subsequently transferred to the MB PhD program at University College London and completed an intercalated PhD in molecular pathology. Dr. Hunt then completed his foundation and core medical training in London before relocating to Southampton in 2012. He has co-authored several peer-reviewed articles about PURA syndrome, including one of the first two papers characterizing PURA syndrome in October 2014. He was also involved in organizing the first PURA syndrome annual conference in the summer of 2015, and he continues to work closely with the PURA Syndrome Foundation. Welcome, Dr. Borelli and Dr. Hunt.
Many thanks for the introduction. So it's an honor to be able to give a talk about the PURA Syndrome Global Patient Registry. As you know, this has been something that has been in the pipeline for some time, and it is now finally live, which is fantastic. And we wouldn't be at this point without the support of the PURA Syndrome Foundation. I apologize to the viewers that my camera is off at the moment, and it will remain off for the duration of the talk. Professor Borelli is here with us as well, and hopefully at the end of the talk we'll have time for some questions and answers. What I should say to you at the very beginning, just to set expectations, is that this is not a deep dive into the data that we've collected so far. The registry, as you know, is in its infancy. We've only been collecting data for the past 5 months, and so I've just scratched at the surface with some fairly easy statistics that I'll show you in the middle of the presentation. Right, so what am I going to talk to you about? So I want to explain to you why natural history studies are important, particularly for rare disease. I will then give some background to the PURA Syndrome Global Patient Registry and explain exactly how it came about, and also give a little bit of an explanation as to why there were some unexpected delays. I will also describe the setup of the registry so that you understand where it's hosted, how it works, who has access to the data. As I mentioned, I'll also give you just a few simple summary statistics that I've extracted from the data over the weekend. And I will explain where we will go from here and how we get there. And hopefully at the end of it, people will be motivated to register, because actually the registry only has value if it has data. So I'm just going to quickly address my colleagues. 1 second, sorry. I do apologize for that. Sorry, that's the problem with giving a presentation at a place of work. Anyhow, so why are natural history studies important? Well, they are very important, particularly for rare diseases. And as I'm sure many of you will appreciate, when a condition is described for the first time, there's very limited information available. And so when PURA syndrome was first characterized in October 2014, we weren't describing it as a new disease. It hadn't suddenly appeared in 2014. It is age old. As long as man has been around, PURA syndrome will have been around. But of course, our understanding of many rare diseases has been facilitated by really major improvements in sequencing technologies, especially with respect, of course, to genetic disorders. And with the advent of exome sequencing, we were able to unpick the causes of very many different disorders, particularly neurodevelopmental disorders. And so when those first papers were published in October 2014, we had just over a dozen or so patients that we knew about who were informing our understanding of the condition. But unfortunately, when the first papers are published, they're often subject to ascertainment bias. And what that means is that the individuals who are involved in those studies often have features in common and typically tend to represent the more severe end of the spectrum. It's not always true, of course, but often there is a bias, and there is a reason why those individuals ended up in a paper together. Either they had to meet some eligibility criteria to enter a research study, and that may or may not require the presence of certain characteristics, for example. And of course, those characteristics may not be present in all patients who have that condition, all affected individuals, and therefore a group of individuals will by definition be excluded. So with time, what we hope to do as the advent of technology has basically enabled us to access these broad tests more easily and cost effectively, is we hope to extend testing to a wider range of individuals. And of course, some of those will be found to have different phenotypes, but similar underlying genetic changes. And through that process, the spectrum of disease typically tends to expand. And of course, when we think about genetic testing, most testing takes place in children, and so less tends to be known about older affected individuals. And that was a point that was raised in the previous talk that I had just tuned into. So one of the things that is often asked of a doctor, particularly a geneticist, when they are giving a diagnosis of a rare disease to a family, is what the implication will be for the affected child in terms of their long-term prognosis, particularly with respect to life expectancy. And that can be very difficult, especially early on, where most of the focus tends to be on a small group of individuals who perhaps have appeared in papers because they have certain characteristics. And oftentimes there won't be a wide representation of a whole population. And because the focus is on younger affected individuals, we often don't actually know what the long-term outcomes are. And the only way that we can find that out is by following individuals who we've identified, and also ideally through extending testing to other groups. Although I have to say, as a geneticist, it's relatively rare that adults with significant neurodevelopmental disorders are referred to clinic for investigation for an underlying cause. So the other thing that's really important with rare disease is that rare manifestations are often not easily detected. And it isn't uncommon that there can be unusual clinical features in affected individuals with a given genetic disorder. And those may be features that haven't been previously recognized in association with that condition. And it may be that the population is very small. And so knowing whether that's a true association, a true complication of that condition is sometimes very difficult, because actually in order to know whether rare manifestations in rare disease are real, you need relatively large sample sizes so that they're adequately statistically powered to make calls about enrichment of certain manifestations or complications compared to a control population. And then I suppose that the main benefit of a natural history study is it enables this thing that we call deep phenotyping. So it really is about gathering highly detailed information about an individual's clinical history and physical characteristics and investigation results that enable us to understand the full breadth of a disease, and also how it evolves over time and what the long-term implications will be for individuals who have that disorder. So what we would hope from a natural history study is that it will identify quality of life issues and care needs that are important for affected individuals, so that those needs can be met early and appropriately. We would also hope that if we have sufficiently good data, that it may influence management guidelines in terms of determining which baseline assessments should be performed, what sort of things a clinician or a parent needs to be vigilant for, and whether there should be any specific surveillance, and also whether our understanding of the condition would influence a choice of medical or surgical intervention for any given issue that may arise as part of that disorder. And sort of drilling down into the molecular genetics of genetic disorders, we like to try to establish whether there are any genotype-phenotype correlations. So this is basically looking at the nature of genetic changes within a gene to see whether specific changes are more likely to be associated with certain problems. So in PURA syndrome, for example, the question might be, if an individual has a particular genetic change, say for example the recurrent phenylalanine deletion, then would they be more likely to develop orthopedic problems, for example, problems with bones? And we don't know the answer at the moment, but it's only through gathering very detailed information over a long period of time in a large population that we'll be able to determine whether there are any genotype-phenotype correlations. So some background to the PURA syndrome global patient registry. So this was something that we had envisaged very early on, and at the first meeting, first international meeting, I should say, in 2015, just outside London, during the research discussions, we were thinking about how we could try to drive our understanding of PURA syndrome. And one of the things that we recognized at that point was that we needed the best possible clinical data that we could get about individuals with PURA syndrome. And so we had this idea of trying to establish a patient registry, because we thought that that's the way that we would be able to systematically collect data that was robust. And the way that we wanted to do that was twofold. We wanted families themselves to be able to provide data about affected individuals. And we also wanted the responsible clinician to be able to provide information about the same affected individual, so that together those were complementary sets of data that would help us to understand the natural history of the disorder, but from slightly different perspectives. And I think that is important because clinicians tend to be focused very much on the physical disease side of things, whereas for families, the focus may be on the day-to-day in terms of care needs, or the things that actually are perhaps presenting the greatest difficulty in terms of accessing support, and only by developing appropriate performers and gathering that information are we able to meet everybody's needs of what a patient registry should be. And the registry has been made possible through various generous donations, especially from the PURA Syndrome Foundation. So thank you again for the support that you provided in making this happen. And there have also been some donations from private individuals too. And together those have all been very generous and have supported not just the build of the registry, because we've had support in doing that from other groups as well, but actually in resourcing this through buying people's time so that all of the administrative work that needs to be done in order to make a registry happen can actually be done. And I'll come to that in a moment because it really was a mammoth undertaking. But back at that first meeting, we had a vision of how research should look for PURA syndrome, and we had broadly broken it up into 4 areas. And the first area in the top left there talks about the natural history of the condition and why we thought that would be important. But then we were also thinking about functional work to better understand the basic science of PURA syndrome, translational research to see what sort of things might be possible in terms of potential therapies, and also sort of cross-cutting research, so thinking about how we can learn about PURA syndrome from studying other conditions in which the PURA gene might be important. So the Global Patient Registry was officially launched in January 2022, and it was amazing that we got there in the end, because it did feel like a very long journey. It is formally known as the PURA Syndrome Longitudinal Natural History Study, which is a bit of a mouthful, and that is why we refer to it more simply as the patient registry, which it is. The principal investigator for this research study is Professor Borelli, who you may hear from a little bit later. So the study itself received approval from the Health Research Authority in 2019, but it was a difficult process in getting there, and this data protection impact assessment was a big piece of work that had to be done. And I think that this was part of the GDPR regulations that were introduced in 2018, and very fortunately we had help in getting that done through a clinical fellow. But the registry itself is based in Southampton, and the Clinical Informatics Research Unit at the University of Southampton has been instrumental in making this happen. And CIRU is led by Professor James Batchelor, who's a professor of clinical informatics and healthcare innovation. And CIRU is is a global player, I think it's fair to say, in clinical trials solutions, and it provides the front end of the patient registry. The back end of the registry, so the database itself, is provided by Forms Vision, which is a company in the Netherlands, through their product Alia, and all of the data that we collect is sort of sorted into data tables using that product. So the registry itself is entirely web-based. It is accessed through this web address, and you're met with a very simple landing page where you have to enter a username and password. But applications to join the registry can be made by parents or guardians or clinicians. You will only be able to access the registry once your email address has been authorized. And so to get authorization to access the registry, you need to submit an expression of interest to the pura@sutton.ac.uk email address, and that must include the individual's name, date of birth, and country of residence. So once those email requests are submitted, they're then picked up by one of our research nurses, Tessie Thomas, who has some of her time funded by the PURA Syndrome Foundation. And she then checks to make sure that the eligibility criteria are met for authorization of the email address. And once that happens, you will receive an acknowledgement, which is sent with instructions on how to access the registry. Once a user accesses the registry with their validated email address, they are then prompted to go through a process of creating a sort of an initial profile, which literally uses chosen initials for the subject for the registry, and the parent or guardian can choose those initials, which are then mapped to a code for the registry as an identifier for that individual. But that's not a full profile, it's just for the user's reference, and they will then have to look at the study information documents that are hosted within the registry, and will need to complete the online consent form before they can actually generate a full participant profile with any demographic information whatsoever. And no clinical data can be collected before the online consent form is completed. So the way that the registry has been designed is as a modular system. So that was simply so that as and when we are able to put together new systems-based modules, they can just be plugged in to the existing setup and will just appear as a new option, as essentially a questionnaire. And most of these modules have radio buttons with pre-selected answers, and some of them have free text questions. Or free text answer boxes. So at the moment, there is one demographic module which you're taken to after you've completed the online consent form. So obviously that asks for the participant's name, date of birth, sex, those sorts of things. And also asks for information about the responsible clinicians. And that's so that we can make contact with those individuals at some point in future to invite them to also submit data to the registry. There are currently 8 systems-based modules which are listed on screen. And these are, as you'd expect, a genetics and family history module, the pregnancy, birth and newborn period. The developmental milestones is quite a big module that's been split into 2 and covers pretty much all aspects of development. A neurological history. Then there's a specific seizures and epilepsy module, which only opens up if you select that the participant has had seizures in their lifetime, and there's a growth module and also an endocrine module. So who has access to this data? Well, the data is held securely and complies with all data protection regulations, specifically GDPR. It is a secure data set that is only accessible to those with study administrator status. So that's half a dozen individuals at most. So study administrators are people such as Di and myself, and also some authorized members of CIRU. There is provision for us to make anonymized data, so basically output data from the database available to approved researchers, but that would be by application only. So the data is not put anywhere else in a public domain in its raw form, and it would not be possible to link that back to any individual. So if it is exported, it will be anonymized and only to researchers who have been approved to access the data. So it has been, as I say, a longer than expected journey, and the General Data Protection Regulation, which came into effect in the EU in 2018, provided an additional hurdle for us in that it sets very high standards for data protection, and that was part of the data protection impact assessment that was mentioned earlier, and we're very grateful to Rebecca Morby, who was our clinical fellow, who was funded to do that work. And so she was with us for, I think, just over a year, and went through all of the groundwork of submitting the various documents that were required in order for us to demonstrate that we would be compliant with GDPR. And ultimately, while she was here, we managed to get ethical approval to run the study. So many thanks to her. And then, of course, there have been a few things that have happened in between, not least COVID. But when we started to get back on track in 2021, we were able to go into a phase of live testing, so using a production environment, but that was a very low scale affair to iron out any last problems before we officially launched the registry to the whole of the PURA syndrome foundation and its membership. And indeed, you don't need to be a member of the PURA syndrome foundation. Anybody with PURA syndrome is welcome to join the registry. And it's not just limited to PURA syndrome, it is also limited to, it is also open to those with 5q31.3 deletions or duplications, so copy number variants that also include the PURA gene. So just a very brief look at the data, and it really is just scratching the surface, because we so far have only 35 registered users. Of those, 33 went on to fully consent participants. So 2 of the registered users stopped before getting to the screen where they have to complete the online consent and then go into the demographics modules. So for those 33 who completed the online consent form, everybody then went on and completed the demographics module. They were then presented with the 8 clinical modules, and as you can see, the breakdown there shows that only 20 of the registered users have completed all 8 clinical modules at the moment, and then there's a smattering across a partially completed numbers of modules there. But at this stage, it would be quite a lot of work to do a deep dive into the data for such a limited data set. So rather than spending hours generating data that won't be that helpful, because there are already more than obviously 20 affected individuals in the published literature. There is a very large number in the published literature now, but what we don't have is the layered data, so that we are systematically and iteratively collecting data year on year to build a natural history of the disorder. But access to the registry has come from a range of countries. So the biggest single representative is the United States, but you can see that probably approaching 2/3, probably 5/8 at least, is from the rest of the world, and a few different countries are represented there, mainly European countries, but we would hope that over the course of time, access widens, and that we have representatives in the registry from all continents. So in terms of gender, there's a slight preponderance of male subjects. There, interestingly, was one individual whose sex was not stated in the demographics form. So things like that are in need of resolution. So I suspect that we'll develop a protocol whereby we can specifically go back to prompt users to complete forms which have been partially filled with some fields left blank, because obviously knowing the sex of the participant is potentially important if we're looking for correlations, for example, in terms of different clinical features and whether they're more likely to occur whether you're male or female. And then the age distribution. So this is not a surprise that most of the patients that we have in the registry so far are under the age of 5 in terms of those 5-year intervals. So that's our modal group, if you like. And again, we would hope that we would have long-term follow-up of all individuals who are in the registry, and there will be a process for going back year on year to contact users to prompt them to provide updated information. So once participants are in the registry, we would look to layer the information that we've got with up-to-date information each and every year, and follow affected individuals throughout the course of their lives. And then just because these statistics were easy to pick from the data that we have in the spreadsheets, I have just presented the parental age at conception, and you can see their mean age for fathers at conception was 33, and mean age for mothers at conception was 31. And then with PURA syndrome, we tend to think of this as being a condition where there's a tendency for post-term birth, and you can see that there are 5 individuals out of the 26 for whom we have a gestation at birth available within the forms, who were born at 42 weeks gestation, and it would be interesting to see how many of those were induced, but that isn't something that I've done at the moment. But certainly from previous studies, we would expect there to be propensity towards post-term birth and induction of labour at 42 weeks. So I haven't gone into any great depth in any of the other modules, but the data is there, and obviously each year that is something that we want to do, and we'll need to set aside a lot of time to do it, and it's only really worthwhile doing when we have a large amount of data to work with. But what do we have to do next? Well, engagement is the main thing. We have to find a way of convincing families of individuals with PURA syndrome that the patient registry is worthwhile. We really do need more data if this is going to have any value, and it could be an extremely valuable resource to the community. As I mentioned, the data analysis is very time consuming, and it certainly won't be informative on the size of sample that we have at the moment. Once we do have data from a significant number of individuals, and really we're talking in 3 digits here, so ideally more than 100, we should be able to generate some reliable data. And of course, the plan will be to update that annually and to present it at the PURA Syndrome Foundation annual conference. We would also like to add new modules. That's how the system has been designed. Currently, we're thinking about modules for the respiratory system and for bone in particular, so orthopedic complications. But really, we need the input of some specialists who have some expertise to help guide how those modules should be designed, particularly the clinical modules, so the ones that the clinicians have to fill in, where there will be a request for a much higher level of detail than in the forms that are put to parents for completion. The natural history, as I say, will be captured by this iterative process of going back to families and asking them each year to provide up-to-date information. And conceivably, that could mean that we would even have PURA specific growth charts, for example, if we're recording height, weight, and head circumference measurements of males and females throughout their lives. And if we've got 100 or more patients, there's no reason why we shouldn't be able to generate those sorts of resources. And so far, all of the data that we have in the registry has come from parents or guardians. However, we do need the input of clinicians. We haven't actively sought that at the moment, but there are complementary modules. So for each of those 8 modules that you saw earlier, there is a module to be completed by the parent or guardian, and a matching module that differs in the detail and nature of information that's requested, that is to be completed ideally by the clinician if they will engage. So we would plan to contact the responsible clinicians at some point in the future. We haven't determined exactly when we should do that. That will be quite a resource-intensive process, because we will have to try to make contact with clinicians individually and see whether they would be inclined to provide data. And of course, they may well need to come back to families to seek their consent separately. And there may be additional things that they have to do in terms of obtaining research consent from institutional review boards to share clinical data. And we need to think of a process that we can use to make that easier for clinicians, because that could be a lot of work just for a single patient. And then in terms of generating output, this is a big thing. There's no point in collecting data and siloing it. We need to actually be able to process that data and generate meaningful output. The PURA Syndrome Foundation annual conference will hopefully be a mainstay where we can properly process the data and provide summary statistics across all of the modules going forwards. But we would also like to use the data to write more peer-reviewed publications. And I think many of you may be familiar with the documents that I've listed at the bottom. So the Unique Disorders Guide and also the Gene Reviews article that we've written, both of which are outdated now. And the best way to update those would be to use data from the patient registry. But we probably will need to get to a stage where we have input from clinicians as well before we start to do that. And then the next big initiative really is to link the registry with the biobank. So the PURA Syndrome Biobank will be based at the Helmholtz in Munich, and we need to link together with them. And the plan is to use pseudonymized identifiers, because we can't transfer patient identifiable details in between the registry and the biobank directly. So there will be a linked identifier, if you like. And in order for any samples to be deposited in the biobank, the clinician who is making that deposit will need to they'll need to use the pseudonymized identifier to access the registry and to provide the associated information describing the sample, the conditions under which it was taken, and that will also link to specific modules that need to be completed. So, for example, if a bone sample were deposited, then we may want to prompt them to complete a module about the bone phenotype in their patient. So if you are thinking about joining the patient registry, it is really very simple. To begin with, all you need to do is send an expression of interest via email to the pura@sutton.ac.uk account. Again, just to emphasize, that needs to include the affected individual's name, date of birth, and country of residence. And you need to confirm as well that you have either parental responsibility or guardianship status for that individual. Once the account has been activated, you'll receive an email, and that will give you instructions on how to access the registry, and also a user guide, which is a step-by-step guide showing you literally which button to click at which point in time and what sort of things you need to enter in order to progress through the system. And I think that's important, because I should say that the system was designed primarily for clinical trials. So the front end is not the sort of graphical user interface that you might expect for most sort of web-based applications. So it is important to follow the user guide in order to access the individual modules. But once you're in, it's really very straightforward to work through them. If you do have any queries and you'd like support, then you can contact the PURA@sutton.ac.uk email address, and either Tessie or I will get back to you. I should also just make clear that enrolment doesn't happen once your email address is authorized or validated to access the registry. It's only once you've completed the online consent form that you have technically entered the study. And there is a process for withdrawing consent and withdrawing from the study, and that's included in the study information documents within the patient registry. So important to look at that. But we're hoping that people will stay in for the long term, because that's how we'll gather the information that we need in order to build a profile of the natural history of PURA syndrome. There are quite a lot of people to acknowledge, so I have to thank all of the members of the Clinical Informatics Research Unit, not least Professor James Batchelor, who's the director, who was very enthusiastic about the prospect of using their expertise to build a patient registry. Richard Munday has been with us from the start and has always been very, very helpful. Most recently, Jessica Vauxhall has joined us, and she too has been really helpful in guiding me through the workings of the registry and how the data tables are formulated and stored. And previously, Nicole and Kevin were working very closely with us. Of course, I'd like to thank the PURA Syndrome Foundation as well. The board has always been very supportive. Amanda and Dom and Heather have all been involved at different points with the patient registry, whether conceptually or trying to get it off the ground and to think about the funding that's needed to make this work. There have also been others apart from the PURA Syndrome Foundation who made donations to support the registry, and we're thankful to everybody who has supported it financially. Dr. Rebecca Morby, who was with us for a year or so as a clinical fellow, really did sterling work in getting through the grind of having to complete all of the paperwork that was necessary in order to get ethical approval for the study. Tessie, who has recently joined us, well, since January, I suppose, has joined us, or a little bit later. And she is our sort of go-to for the pura@sutton.ac.uk email address. So if you make contact, she's the person who's most likely going to respond in the first instance. And then finally, I should also thank Mel Anderson for her tireless support over the years in trying to help us get this off the ground. She really has been invaluable and continues to help us in thinking about how the biobank can tie up in practice with the patient registry. And that's pretty much everyone, I think. So now we should have some time for questions and answers.
Yes, thank you, Dr. Hunt, for that wonderful update. We do have a fair amount of questions for you. The first is, how will the application process work in order for researchers to access data from the registry?
So that's a good question. So there is a registry committee, and that is also one of the committees that is linked to the PURA Syndrome Foundation. At the moment, the protocol hasn't been finalized, but it is, or at least I don't think it has, Di, but it is something that we have stated is part of the aim of the registry, because the purpose here is not to have ownership of data and to silo it and protect it from other researchers. Actually, we want people who have something to offer to be able to access the data. All we need to know is what they want to do with the data, and make sure that they only have the data that they need to do that with, and that it is it protects the identities of individuals who have submitted it. So there will be a process whereby applications can be made to access the data. There will then be a review process that will involve members of the registry, probably members of the PURA Syndrome Foundation as well, to determine whether those applications should be supported or not. And if it's decided that access should be granted, then we need to decide how the data will be presented to those research groups and define what exactly can be done with it.
Okay. All right. The next question is, have you gathered feedback from parents about their experience filling out the registry? I'm wondering why there are so few people who have registered so far.
So we haven't actually, and we didn't build in a process to go back to individuals to, oh, sorry, Di, I think you were about to say something.
We did test it out at the beginning with a handful to iron out some glitches, but you are right, we need to have a feedback process now that more are inputting the data. Sorry, David, carry on.
No, that's okay. So we haven't agreed a protocol for contacting registered users who got as far as the consent form and then didn't complete it, to say, was there something you didn't like about the study? Did you find the interface difficult to use? What seems to be clear is that of those 33 registered users who have consented a participant in the study, they have all gone on to complete the demographics module. The vast majority of them have completed some of the clinical modules. Whether they have stopped because they intended to come back at another point, there are a lot of fields that need to be completed, and in the user guide I have suggested that it's probably not something you want to do in one sitting. You probably do want to do it over the course of several sittings with whatever medical records you have in terms of clinic letters to hand, and there really is no urgency to complete it. I think that actually it's fine to go away and come back. What isn't clear to me is why some of those modules have never been come back to, whether people have just forgotten that they needed to do that, or have gone away and I've thought, well, perhaps I'll do it next time when I get an email reminder to update the data. So it'll be interesting to see a year on how many of those people go back and then complete the missing modules. But we hadn't anticipated that people would stop partway through, and so we did not agree a process for emailing people to prompt them to complete modules, and that's probably a dialogue that we need to have. And I don't know what is written in the research ethics approval that we've got about contacting users other than at defined intervals. Presumably that is something that we can do, but I need to look at the actual wording of the approval that we have to see if we can build something around that to prompt individuals to go back and give us a full data set, because actually incomplete data sets are very tricky, and it would be nice if we were looking at mainly having full data sets. But I'm hoping that because we have this agreement to contact users yearly, that when we do that, they will at least go and complete those modules that they haven't completed. And we can certainly write something into the annual reminder that if there are modules that haven't been completed, could those please be completed when they next review the data.
Okay, so the next question is, I received an email a couple weeks ago for initial setup for the registry, which I did. I was supposed to be contacted for further instructions, but I've never had a follow-up contact. Is there something else I need to do? So maybe just a general, like, how much time will it take for people to follow up or expect an answer?
So it shouldn't take long. So Tessie is checking the email, I think at least twice per week is what was agreed. So there could be a lag of a few days, but it shouldn't be weeks. So the only thing that I think we need to check is that emails, so I suppose my question is, was a response received at all? Presumably there was, from the way you phrased the question, but you didn't get any subsequent follow-up, is that right?
I'm just looking to see, Mina, hold on one second.
Because otherwise I think if you could ask whoever's put that question to email again, then I will talk with Tessie and we can try and locate the email. I'm just worried that perhaps some emails might not be going into the inbox, but maybe going into spam or junk or being filtered by the university system. Hopefully that's not happening, because we did check that previously, and we corrected a filter that had removed some emails. So that shouldn't be happening anymore. But if you ask them to email again, we'll look and we will respond.
Sure, I will. I wrote that answer right back to her, so. All right, so the next one is, there were some terms on the registry form like beaker, which don't translate in the US. We would say a cup. How are you accounting for these differences?
Yeah, I think we have to find shared language where there can be no confusion. So I think terms like that we can change. So we could change that to either a closed top or open top cup, or something that is not going to be confused depending on where you are in the world and how you use that, or how you use that word and what it means to you.
Okay. All right. Back in 2018, I was told that a patient registry was being established, and I filled out a long form, as did my epileptologist. My daughter is in her 50s, and it was clear that information is not there. Any thoughts of what might have happened to such earlier data?
In 2018, I'm wondering if this is for one of the peer-reviewed publications rather than the patient registry. As far as I'm aware, there was no data that was being collected for the patient registry then. So the registry itself went into a phase of live testing on a very limited scale last summer, with just a few users so that we could work through any problems. But that was the first time that we started to use the production environment. So before that, it was a UAT environment. So it was entirely a test environment. And I think in 2018, I'm wondering if this is perhaps information that was collected for one of the peer-reviewed publications. I don't know. I don't know if Di is still on the call with us, but I'm not aware that any data was being collected for the registry in 2018, not from patients. It shouldn't have been.
I am here. I just have to apologise to everybody because I'm at the European Society of Human Genetics conference in Vienna, and that's why I'm not there. And I am here, but sort of in the background. But I agree, David. I think we did have pro formas that had to be filled in, but it was for papers, not for the registry. So it must be that.
Okay.
That's what I think as well. So I think there may be some confusion over where that data was going. So if a clinician, an epileptologist, was also providing data, almost certainly that would have been going into a publication, I think.
Okay. All right. Is there a timeline for developing that protocol you mentioned for researchers to apply for access to the data? She said, great to hear you want people to be able to access the data. Thanks.
Yeah, well, we do want people to be able to access the data. We need more data first. So I guess the immediate focus is on how we increase engagement, but that will be something that we need to address fairly soon. We haven't set a timeline for that at the moment. But I would hope that we'll be much closer to that by this time next year. And if we have a decent amount of data, and really there's no reason why we shouldn't have, because the system has been built, it's just a matter of people using it now, then that will have value. And actually we need people to be accessing the data in order to make the most of it, because it was never proposed that we would be the sole analysts of the data. It was proposed that we would host this and make it available and encourage appropriate research. And so if there are people who want to use the data, then yes, we absolutely need to make that happen. And I think that if people who are interested in accessing the data want to establish contact through the pura@sutton.ac.uk email address, then at least we can keep them abreast of developments on that front, and enter into direct conversations with them, because it may be that, you know, we could expedite that process. Well, I can't hear you now.
Yeah, I didn't unmute, sorry. Amanda just actually put something in the chat. I can help answer that question too. I agree with David that by the end of this year and before the conference next year, we should have a protocol and steering committee for the registry. However, we really need people to complete the registry. We need data for researchers to access. So, again, just a reminder to people, if you have questions, the Q&A, that chat just popped up, so I haven't really been checking the chat. So if you do have questions, the question and answer box, please. And then one of the questions, so actually another comment was saying, I'm also in this situation, no email after the registration. She sent an email to inquire, no response still, and she registered a week before the conference.
Okay, so what I'm going to do, can I ask the people who are on the call who've previously contacted or sent an email to the Sutton or pura@sutton.ac.uk account to resubmit their request, please? And I am wondering if it's possible, because the thing is that I need to know who's actually trying to make contact to see if those emails are reaching us or not. So we probably need a way for somebody within the PURA Syndrome Foundation to keep a list of those individuals so that we can trace back to them if we haven't received the email as we would expect. So it may be that there's an issue with the account, but I'm pretty sure that it should be working, because the only problem we had previously was the junk email filter, which we sorted out. So, so please do email again today, and I will check with Tessie tomorrow and respond to any requests that we get to join the registry. And then what I will also do, if you've got a separate record of who's asking or who is commenting on this difficulty, then I can contact you tomorrow, Liz, and we can see if there are problems with the email account, in which case we'll need to go to the University of Southampton to find out if the emails have been blocked. But you should receive a notification if the email hasn't reached the Southampton account.
Okay. I took down a couple of the names of the people that mentioned it here, and then Amanda also mentioned to also feel free to email her, and she can follow up with you and Tessie.
Yeah, that would be great, actually. Thank you.
Okay. I don't see any more questions or questions here. So if no one else has any questions, I'd like to thank you very much for your time, Dr. Hunt, and then ask that for our next session, our next session is promoting health, healing, and well-being through food as medicine, and that will start at 12:30 p.m. So thank you again very much.